I'm Juliana Jaramillo. I'm one of the third years. I'd like to give a special thanks to the CCM team, Dr. Tupler, Dr. Capawala, and Dr. D'Souza. So we're going to be discussing a case. We have a 55-year-old gentleman whose chief complaint is upper extremity pain bilaterally. He says, I fell in the house and basically both of my wrists are fractured. So from the HPI, we get, he's coming in with bilateral wrist pain and swelling. He said that he had a fall. He says that this pain is constant, it's sharp. They said radio buzzing, I'm not sure what they meant by that. And it's just very intense. He says that it's red, it's swollen, he's been having chills and he feels cold. But he says he hasn't been having any fevers. He says he didn't pass out with the fall, not complaining of any weakness or numbness per se. So he takes no medications. He has no allergies. In terms of other additional aspects of the history, he is a drinker, and he also occasionally does cocaine and marijuana. Otherwise, never been out of the country or any other aspects there. So these are your vital signs. So we see he is tachycardic to 120. Otherwise, the rest of the vital signs look pretty unremarkable. So at this point, can anyone give me any potential problems?
Alcohol withdrawal. Yeah.
Okay.
Broken wrist.
Stinking pain, tachycardia.
Okay. So at this point, we're kind of staying pretty general still. So yeah, tachycardia, wrist pain, could be fracture, could be a million other things. And yeah, alcohol dependence, maybe withdrawal. So at this point, we're just going to talk about the initial interventions that they did. So it looks like it was kind of change of shift, and the previous team had ordered him some medications. So they ordered him 6 of morphine, and then when the next shift came on, I guess he was still in a lot of pain, and they ordered 1 milligram of Bilateral. Next, we see they ordered Ativan, they ordered Librium, Thiamine, normal saline. We ordered an EKG, sent off a shock panel, and they asked for a rectal temp to maybe look into what else is going on with his tachycardia. Any questions so far just on the history?
What's going on with his wrists?
No X-rays?
No physical exam.
So not physical exam yet.
Okay.
We're just strictly history.
Why did he fall?
He said he was drinking and just fell in the house. Nothing really more descriptive than that.
Is he having any other trauma or complaints?
Nope. Just no. Just basically complaining of pain at the wrist. Yeah.
How does he know his wrists are fractured?
That's just what he said.
That's what he said.
Yeah, that was literally taken from the triage.
Is he?
All right.
What was his last drink? Like, you guys didn't ask that.
His last drink was the night before. Yeah.
He says he doesn't take any medication. Is he supposed to take medication?
No medical problems. Or actually, I think maybe potentially hypertension, but nothing serious.
Has he been in good health?
I don't know that.
Has he been in good health recently? Has he been feeling sick? Anything else?
Yep. He's been in his usual state of health, drinking, working, whatever, and he just fell, and he's coming in because he has pain to those ribs.
Has he been having trouble walking?
Nope.
Anyway,
Sexual history?
That I don't know. Alright. We're going to keep going on unless there's any other pressing history questions. Okay, so we're going to get into the exam. So overall, they say that he appears really uncomfortable, he's in pain, he's tremulous. On HENT, they notice that he has a tongue laceration. They say that he's really dry. His conjunctiva is normal. In terms of chest, he's tachycardic. There's no murmurs that they appreciate. His lungs are clear. Abdomen is pretty much unremarkable. He's non-tender. So extremities. And this is pretty much taken exactly from the note. He has bilateral erythema. They're both swollen. They're both tender. There's not much more descriptions to that. And otherwise, he has no other rashes anywhere else, and he has good pulses. In terms of neurologic, they say that he has 2 out of 5 strength in bilateral upper extremities. But otherwise, he's intact. So questions up to here. Yeah.
With the 2 out of 5 strength for the entire shoulder or just at the wrist?
They did not specify, but they did comment that they thought that this was maybe related to pain and maybe not necessarily weak. Yeah. They did not comment, but I don't believe he had any.
What was the comment? I didn't hear.
Disease spine tenderness.
Oh, or just spinal tenderness in general? Any, I mean, was any sensory exam or like specific nerve exam, peripheral nerve exam done?
They just basically said sensation intact, nothing super particular.
I'm sorry, non-exposure, was it anything else noted?
No.
To-
It's essentially just literally wrist on both hands.
And he was tremulous, was he fasciculating?
So that actually was not documented, and when I spoke to providers, they could not really recall. They just said that he looked shaky.
And was he alert and oriented?
Yes. He was alert, oriented. He walked in. This was not like he did not come in via ambulance. He was just like, I think my wrists are broken, so I came to the emergency room. He was totally with it.
Was the patient exposed? Who knows?
Realistically, that I don't know.
18 all the way.
What? All right, we're gonna keep going. So up to now, can you guys throw out some differentials?
Wrist fracture.
Withdrawal seizures.
Okay. What was that?
Infection.
Okay.
Again, stringomyelia.
Sure.
Subdural hemorrhage.
Okay. Fall. Huh?
Thyrotoxicosis.
Thyrotoxicosis. Okay. So, here are a few that we put up here. So, yeah, he could potentially have a fracture. He could have sprained it. He could have something like gout or any other sort of crystallopathies. He could have sepsis. He has tachycardia. With maybe some cellulitis. He could maybe have endocarditis, and so you have this weird bilateral wrist. It could be septic arthritis, although it's weird that he has it bilaterally. Or he could have had, actually, maybe he had a withdrawal seizure, and maybe that's why he has a tongue laceration. So these are just a few. So going back to check on our patient, he has a rectal temp of 103. And now he has decreased mental status. So he gets transferred to CCT at 9:45. He came in at like 6:30. And then a repeat set of vital signs before going to CCT. We see that his blood pressure is now borderline hypotensive. He was 144 over like 75 when he came in, and now he's 92 over 75. His tachycardia is getting worse. He's in the 130s, and we see that he's febrile at 103. So this is his EKG. Does anyone want to take a stab at it? Okay.
Or maybe
So Ron, do you want to just,
No.
since you're laying down? Okay.
I can barely see it.
All right. So basically, we see that it's really fast.
Other D-waves, I can't see them.
So that was actually up for some debate, but I do see some areas where you can kind of see that maybe it looks like the P and the T waves are getting joined together. It's just that he's really tacky. This is a rate in like the 160s.
What was the QTC?
It was 428.5. But but yeah, it does look maybe prolonged. Okay? So maybe sinus tach, maybe, I don't know, I think I potentially see this, but we'd have to slow him down to get more. So this is his shock. So he has a lactate of 13. He's hyponatremic, he's hypokalemic. His pH is actually okay. Bicarbs bicarbs may be a little low. I'm sorry? Oh, I didn't put the glucose, but his glucose is like 100.
There's no way his respiratory rate is 20, I'm just saying.
Yes.
It's 40.
Yes. All right, so we'll talk a little bit more about this in the future slides. So, what are some other things that we might want at this point that we haven't seen?
So, like, make sure the patient's really undressed. For any head trauma, this is belly soft. I would do fast. I would do a full trauma workup on this guy.
So we want x-rays, chest, ribs, forearm, everything. We want to send some labs. We want to send a CBC, a comp, magnesium coags. We want to get blood cultures, he's febrile. We don't really know what's going on at this point. UA, tox, I mean, it doesn't really fit necessarily a toxidrome, but and they also got ortho involved because again they were concerned about potentially a septic joint for arthrocentesis. Yes, they did get a head CT. I did not include that. Sorry. So
They didn't do any. Sorry. Any imaging of the spine? Or anything?
no, but we'll get there. Things start evolving as we go forward. Okay, so here you have the results. There are a lot of abnormalities in here, right? So we see, starting up top, he's hypokalemic at 3.2, his bicarb is 13, he's in acute renal failure with a creatinine of 3.47, he has a large anion gap, he's thrombocytopenic, he has an elevated INR, he's hypomagnesemia at 0.6. I mean, this guy's really sick, right? At least based off of this. So this is his chest X-ray. There's nothing there, it's normal. These are his X-rays. There's no gas, there's nothing there concerning, there's no fractures. This is fine. Same thing on the left side. There's like this disease. Okay, so now, do we have any other potential problems at this point?
Shock. He's in shock.
Septic
Some kind of shock.
Yeah. So, yeah, we would probably say he's in severe sepsis. I mean, we still don't really have a good handle of what's going on. Could this be cellulitis that threw him into septic shock? Could this be septic arthritis? He also has all these other issues of hypokalemia, hyponatremia, hypomagnesemia. He has a large anion gap. Potentially. Yeah, definitely. Okay. So on reassessment now it's 10:30. So he got to CCT at 9:45 for maybe a decreased mental status. Now it's 10:30. Now he's uptended. His heart rate is still tacking away in the 150s. He's still borderline hypotensive. And they comment on the fact that he has swelling and erythema to bilateral wrists. The right is worse than the left. And he has minimal range of motion at the wrist. We'll get there. So here are some of the next steps that we want to do. So we're going to send a repeat shock panel. We're going to add on the ESR-CRP. Again, they were still thinking maybe septic arthritis. They added on some tox labs, thinking that maybe could this be tox related. They were giving him fluids. They gave him empiric antibiotics to suffocate and think, and they called him acute. So they did not intubate. So at this point, now you have the CRP is elevated, his CK is elevated, his UA was negative for infection, but was noted to have hemoglobin without RBCs, and he's positive for cocaine and opioids. His repeat lactate came down to 6 after fluids.
What were his platelets?
92.
92. Did they sign DIC stuff? Fibrinogen?
No. Not at that point. Okay, so they had gotten ortho on board. They basically said they had a really low suspicion that this was going to be septic arthritis, but they did do an orthocentesis. They said that they got barely anything out. It was just enough to send for a culture, and it was a bloody tap. They basically said antibiotics, maybe consider an MRI, but they didn't think that was the cause. So then at 1 or so, we got MICU. They basically said admit to the MICU. They wanted him on Prestix. They wanted him to get covered with Ativan if this is potentially alcohol withdrawal. They said to give him broad spectrum antibiotics, obviously cover his electrolytes. They wanted general surgery involved because they were saying, could this be possible neck dash?
Of the wrist?
And then they were saying echo maybe is a endocarditis. So they were thinking at this point, this is septic shock, possible septic joint, alcohol withdrawal, possible DTs. So this is all straight from the McCune. So in the ED, basically he got repleted of all his electrolytes, he got 4 liters of fluid, he had gotten a few doses of opioids with morphine, Dilaudid, he got multiple doses of benzos for whatever reason, he kept getting Ativan. And they gave him cefepime. He had a negative head CT, negative x-rays that they could see at this point. So at this point, he is admitted to the NICU. Gen Surg came by. They basically said that they signed off. They defer to orthopedics if they want to test for neck bash. They don't think that this was them. And then he continues to become hypotensive. They place a central line. He gets started on pressors.
Was he tachy like this entire time?
Yes.
That's terrible.
Did he have a CT with like the aspirin?
So he got 4 liters of fluids. Basically, he was no longer responding to fluids, and so he became more and more hypotensive, and they had to put in a central line.
Has he been intubated?
No.
So you're giving Precedex and all these benzos back.
They supposedly he's still protecting his airway. So. So ortho comes back. They say, yeah, he has this persistent tachycardia, he's still obtunded. And now they say that that right upper extremity cellulitis has now progressed to about the elbow along the medial aspect, but the left side is unchanged. And this is just only, I think it was only like 6 or 7 hours after the initial time that they saw him.
Did they tap just one side or did they tap just a radius?
I believe it was just one side. So they recommend a CAT scan to evaluate for necrotizing fasciitis. So the next day, ortho comes back. They say the exam is unchanged now for 12 hours. The CAT scan has no air, abscess. They just notice edema, that he has significant edema. And then they get ID involved because turns out the blood cultures grew gram-positive cocci chains. So they're saying that this clinical picture is actually suggestive of toxic shock syndrome. So they're saying that basically with toxic shock, they saw that he was an acute renal failure, he had transaminitis, thrombocytopenia, had a very rapid decline requiring pressors, and they're saying that this fits with toxic shock syndrome. So they say consider IVIG, which we will get into a little bit later. And so he gets started on that for 3 days. So his blood cultures and a synovial culture grow group G strep. And ID keeps saying that he may need debridement. And so I'll answer the questions once we get through the hospital course. So hospital day 4, his mental status improved, but he's still incoherent. He is receiving IVIG. They've never noted any symptoms of withdrawal. Ortho came back. They said that the rash is clinically worse, and so they decided to go ahead and do a bedside frozen section of the fascia to rule out necrotizing fasciitis. So basically, this is sometimes done. It's not a common procedure that ortho does, because I actually did talk to them about it. They said that it's, and basically from my reading, they do it sometimes when you have an equivocal diagnosis and they want to evaluate further. So there's actually 2 techniques that they do with this. They do what they call a finger test, and that's actually done at the bedside, where they do like a 2-centimeter incision down to the deep fascia, and they probe to look for the presence of basically dishwater pus is what they say, along with lack of bleeding or lack of tissue resistance can be correlated with necrotizing fasciitis. Essentially, the ortho attending, he said that that the muscle belly looked good, there was good blood flow, there was no signs of pus, there was no signs of any sort of necrotizing fasciitis, at least on the macro level. They did still take a small sample and sent to pathology to look at the micro level. So now in hospital day 5, the erythema extends to the axilla on both sides, and he's starting to develop these bullae on the right upper extremity. So they did call derm. Derm basically says that the findings that they see are consistent with cellulitis, possibly causing severe sepsis. They did a very extensive review of all the skin, and they said basically there's no Osler's nodes, there's no Janeway lesions, there's no involvement of the mucous membranes. They say that they see bilateral upper extremity erythema with swelling. There's no crepitus, and basically everything that they've been commenting on. Ortho comes back, they basically sign off. The micro specimen, the specimen that was sent to pathology was negative for necrotizing fasciitis. So these are some pictures on hospital day 5. So you can see the bullae over the right wrist starting to develop, and you can see that there are areas that are starting to desquamate. It's kind of hard to see the redness necessarily on these pictures, but just to kind of give you an idea. And so now, going through the rest of the hospital course, they said the exam was improving. His blood cultures were only positive on that first day. After that, they were negative. Hospital day 11, he is finally able to have a conversation and follow commands. And then on hospital day 17, he's downgraded to medicine. On hospital day 19, he started to develop necrotic lesions along that right upper extremity, consistent with dry gangrene. And then he was actually able to be discharged from the hospital on hospital day 23. These are just some of the pictures, one of the pictures to look at the necrosis on that right upper extremity. You can kind of tell that the left side actually looks okay. The right side, you have desquamation, it's swollen, yeah, so signs of necrosis.
Did they do the echo?
Yes, it was negative. So in conclusion, you have this 55-year-old male who came in with this bilateral wrist swelling, pain, redness that quickly declined and went into a multi-organ failure. And this was due to streptococcal G causing streptococcal toxic shock syndrome. So, any questions at this point before?
Is renal function improved?
Yes.
So he had any function of his right hand or the right hand was?
Yeah, so actually, I was looking at more recent notes. He's been following up in rehab. He still has a little bit of difficulty with strength in that right hand, but it looks like everything's improving.
Do you take steroids?
No. Yeah.
Strength was seen in both culture sets?
Yes, it was seen in the blood culture and the synovial culture.
No, the blood culture is both sets, or it was only one
I
set?
think only one set is what I saw. Okay. Yeah.
Is he still using drugs? Did you read anything about it? Is anything else?
I don't know. I didn't see that comment. Yeah.
Anybody check for Levanisol?
For what?
Levanisol. It's an adulterant of cocaine that gives you necrosis.
No. That was not investigated.
Did any of the sensitivities
Due to the strength that it gives
Is he done?
He did. It was negative.
They all case.
They did not help me.
They just been energized the whole time and then it got better. 21 days into that.
All right. Any other questions before we go on?
Maybe.
Are you going to tell us his antibiotics that you got now?
He got. He was continued on cefepime bank. They did add Clinda. They actually switched him to Zosyn. So he got Clinda, and bank. And they continued that until the blood cultures came back. And then they started him on the IVIG. And then they got rid of the bank, but they kept him on Zosyn and Clinda. Any other questions before we move on? Okay. So the topic for today is going to be toxic shock syndrome. So we're going to be going over kind of a brief review of the history of it, as well as the pathogenesis. What does toxic shock actually entail? What's the definition of it? And then we'll go over some of the clinical mimics, because this can look very similar to a lot of things. And then we'll discuss some of the treatments. So in terms of the background, toxic shock was actually first mentioned by Dr. Todd in 1978. He had a case series of 7 kids that he said that they had this new syndrome that didn't appear consistent with any other disease processes at the time. And they all had fever, a scarlatiniform rash, injected conjunctiva. They all ended up with shock and hypotension with an organ involvement of kidneys, liver, DIC. They also all developed desquamation. He also, around this time, had noted that Staph aureus had been noted to cause exotoxins and would also cause this kind of positive Nikolsky sign, and you would get desquamation from that. Then in 1985, basically they came up with a formal definition for what staphylococcal toxic shock was, and they had to essentially rule out all other causes. So they had to have negative Rocky Mountain spot and fever, negative lepto, negative anything that could possibly be this similar condition. And then it wasn't until 1987 that they started talking about strep. Strep pyogenes, group A strep, was seen to cause a very similar pathology as what they had seen with Staph aureus, where they also would produce these exotoxins and lead to actually what looked like a more virulent syndrome where you would have the same things of hypotension, multi-organ failure, and a pretty rapid decline. So then they also came up with the strict definition for streptococcal toxic shock syndrome in 1987. So to talk a little bit about the pathogenesis, so you have Staph aureus and group A strep. Essentially, they produce exotoxins and these super antigens that cause massive T cell proliferation and ends up leading to a massive cytokine storm and causing the toxic shock syndrome, because you end up having that massive cytokine storm ends up leading to fever, the rash, the capillary leakage, and causing the subsequent hypotension that we see. Staph aureus tends to be more of a localized infection leading to this, whereas streptococcal toxic shock tends to be more of an invasive group A strep, and so these patients tend to be sicker, honestly. So I'm just going to briefly go over staph toxic shock, even though our patient actually had strep. So with the definition for staphylococcal toxic shock, you will have fever. You end up having hypotension rather early in the course. You notice a rash, desquamation in all of those cases, and you end up having multi-organ failure. And they need to have at least 3 organs involved. So whether that's GI, severe myalgias with elevated CK, they can have involvement of the mucous membranes, they can have renal involvement, hepatic involvement, they can be thrombocytopenic, and they can also involve the CNS system. So actually, just going back, the big thing about this is they have to be negative to, like I said, Rocky Mountain spotted fever. Their blood cultures have to all be negative. Everything has to be negative in order for you to come up with the diagnosis of staphylococcal toxic shock. And so it's really hard to have a definitive answer for this because of that you need negative everything else. Occasionally they say that the blood cultures can grow Staph aureus, and that is seen, but not as commonly for the most part. They do not become bacteremic. In streptococcal toxic shock, it's a little different. So you have to have the hypotension, and then in these cases, you also end up having multi-organ failure. So they comment a lot on elevated transaminitis. They talk a lot about the T-billy being elevated. You can have lung involvement. You can actually go into ARDS with this. You end up having some sort of a rash that they say, they actually included soft tissue necrosis as part of the definition for streptococcal toxic shock. Renal involvement is one of the earliest signs where they, again, look at the creatinine, they look at, you can have this elevated CK, you can have myoglobin, and that's all part of the kidneys starting to fail. Like I mentioned, you can get necrosis, that's also part of their failure, and thrombocytopenia is also seen pretty early. These patients do go into DIC. So one of the big differences here is that you do have to isolate group, some sort of strep. In the beginning, they always said group A strep because that was the only one that they knew. And so if it's seen in a normally sterile site, such as the blood, the CSF, or from a biopsy of some sort, then you have a definitive diagnosis of toxic shock, as long as you have the other aspects. If it's seen in a non-sterile site, as like the throat, sputum, or anything like that, you have a probable diagnosis. They've been noticing in recent years that it's not just group A strep, that there are other subgroups of strep, like group C, group G are ones that are starting to come to light more recently that are actually seem to be more virulent. So there are a lot of things that can mimic this disease, and one of the difficult aspects of it is that in order to treat toxic shock, you have to be able to diagnose it, and there's, like I said, no definitive test for staph, so you basically have to just rule out other causes. So necrotizing fasciitis and cellulitis, abscess, this gets a little tricky because essentially you can have necrotizing fasciitis or cellulitis that leads you into toxic shock syndrome, but you can also have it as its own infection. So you can just have necrotizing fasciitis without the toxic shock, and vice versa. They say that about like 30 to 50% of the necrotizing fasciitis actually do develop into toxic shock syndrome. And the other aspect of this is that these are all things that can lead you into septic shock. Septic shock, it's very confusing in a lot of the literature. They kind of use it interchangeably with toxic shock syndrome, but there is, in some cases, a slight difference. They do say that, particularly with streptococcal toxic shock, you can have multi-organ failure before you get the hypotension. Whereas in septic shock, you typically see the hypotension first, and then you start seeing the multi-organ failure. The earliest things that they see is the renal involvement, the liver involvement, and the thrombocytopenia that throws you into DIC. And then eventually you go into the hypotension. So, just basically the early shock, organ failure, hypotension. With toxic shock, you have a very rapid decline, and the fatality related to it is very high. We're talking like greater than 50%, at least in streptococcal. So other things that can look similar, gout, septic arthritis. So gout tends to be more of a benign process. It tends to be localized. It tends to be unilateral, although you can have it in polyarticular sites. Septic arthritis, you generally see it again at one site. It can throw you into septic shock. However, particularly with our case, it doesn't quite, you don't see it very frequently for it to be bilateral. So that was just something that was always difficult to assess in this patient, although it can happen. And then also with septic arthritis, you don't see quite as fast of a decline. Endocarditis. So he did not have Janeway lesions. He didn't have Osler's nodes. He could have had septic arthritis that maybe he was throwing septic emboli, and that's why he had bilateral wrist involvement. But he, according to like the whole Duke's criteria, he doesn't meet endocarditis based off of that. Like he only had, I believe there was only one blood culture that was positive, and he had fever, so he only actually met 2 of the minor criteria. Kawasaki's disease. It is a disease mostly seen in children, but there are a lot of similarities between the two, but predominantly to distinguish, Kawasaki does not end up having hypotension. The fevers are longer lasting in Kawasaki, and you actually frequently see erythema multiforme with Kawasaki that you do not see with toxic shock. And then other things that could look similar, Stevens-Johnson's and staphylococcal scalded syndrome. So SSS does not typically disseminate. Again, it's seen in younger children, not typically associated with like a circulatory collapse like we do see with toxic shock. And they say that the facial appearance is very characteristic, and it heavily involves mucous membranes, which realistically you don't see as much. Stevens-Johnson's, typically you see it after maybe a change in antibiotics. do still have a rapid rash. You do sometimes have erythema multiforme, which is not seen in toxic shock, and you also have a positive Nikolsky sign, which is not really seen, at least in streptococcal. You can sometimes see it in staph, and that was like in the earlier definition. Yeah. So our case, our particular patient, he did have hypotension. He ended up requiring pressors pretty early on. He had a very rapid decline. He did have acute kidney injury. He had a creatinine of 3.47. He had myoglobinuria. He did have signs of thrombocytopenia, and he did end up going into full DIC. He did have early signs of hepatic involvement because all of those labs were sent much earlier on in the course, and he did already start having a bump in his AST, ALT, and his T-billy was also like 1.5. And then in his case, we did have the rash. It was kind of a generalized erythematous rash that did eventually have desquamation. However, with streptococcal toxic shock, you don't always have to have the desquamation. And then he did end up developing the soft tissue necrosis later in the course. He also did have the positive group G strep in both the blood and the synovial culture. The only thing that he didn't have was lung involvement. So, talking a little bit about group G strep, they do say that it's basically indistinguishable from group A strep, at least in the presentation. Like I said, it's relatively new that they're starting to see more of these cases of group G causing toxic shock. There are multiple virulence factors, all the same ones that you see with group A strep. The super antigens, the exotoxins, are all there. They have been commenting that group G strep in particular has been seen with diabetics, patients who have some sort of hepatic failure. I mean, he was an alcoholic, maybe that had something to do with his susceptibility to this. So far, from what I was reading, there's actually only 15 reported cases as of 2017. I couldn't really find anything earlier than that, or later than that, that have documented toxic shock syndrome secondary to group G strep. And this was actually one of the ID attendings that was on this case actually included this in their consult as evidence. All of those cases, just kind of going through them, look very similar to this patient. They all had a very rapid decline. They all basically totally decompensated within like 8 hours of arrival. Some of them did have similar pictures of what they thought was maybe septic arthritis or something like that. And they all end up growing group G strep. And basically, one of the cool things about this was that they were saying some of them did end up going to get a biopsy done, and at least at the macro level, they didn't appear to have necrotizing fasciitis. But then when they would take them later for biopsy, the pathology did say that there was necrosis there. And then in these cases, they started testing the idea of IVIG, which I'll go into a little bit later. But essentially from these 15 cases, they were saying that there's an extremely high mortality rate in general. They were saying a 66% mortality rate. And again, the IVIG is potentially a treatment to help with that, because the first 12 that they talked about, the mortality rate was like 83%, and then they started discussing IVIG, and then that those next few cases ended up getting treated with IVIG and actually survived. So in terms of treatments, you want to do all of your normal resuscitation. So that includes your ABCs. You want to make sure that they're protecting their airway. You want to give them fluids. Although, like I was mentioning before, what is commonly seen is that they end up not being responsive to fluids and they end up going into hypotension requiring pressors. In terms of antibiotics, you do want to give them broad spectrum, particularly with staph. The treatment that they were suggesting was like oxacillin and methicillin, but specifically for strep, they recommend penicillin, and they recommend an adjunct with clindamycin. Clindamycin, basically it helps to reduce some of the super antigen toxin production. It also helps to enhance the penicillin, is what they have been thinking about, the mechanism of action. However, the studies that they have for this are very limited. Most of them are really retrospective. It's not great data. However, the thought process behind it is that the bacteria essentially goes into a static mode, and so they're not producing the penicillin binding proteins, making it harder for the penicillin to act on the bacteria. And so clindamycin essentially helps to enhance the ability of penicillin to work on the bacteria. Then surgical debridement is basically something that is talked about a lot in all the papers. They kept saying that you want to take them early to check for necrotizing fasciitis. In some of the cases they did see nec fasc, but it doesn't matter that they have normal imaging studies. You can't rely on the fact that there's no gas and that there's no any other specific findings for necrotizing fasciitis. Basically, one of the main findings that they would associate with necrotizing fasciitis was actually just edema. And then, as I mentioned before, particularly with this group G strep from the cases that I was seeing, they may see a normal fascia at the macro level, but then when you take it to pathology, they actually did have necrosis. In terms of IVIG, so this is actually pretty interesting. It's controversial. There's not a lot of data. It's not that common to see toxic shock anyway. But from the cases that are available in discussion with this in particular, basically the theoretical argument for it is that it reduces the toxin load. It gives you humoral immunity that those patients are not seen to have had. So it decreases the production of cytokines, and it decreases the adhesion molecules and neutralizes the superantigens. In terms of the studies that they have looking at this, there's about 4 different studies. One of them is actually a multi-center placebo-controlled trial that ended up getting terminated early because they didn't have enough patients. And then there's 2 observational studies and a case control. Based off of that, I mean, realistically, they were looking at mortality at 28 days, and they noted an increase in mortality in the placebo group quite significantly, about a 3.6 fold higher in those patients. Granted, this evidence is limited because of the fact that you don't have great numbers to look at this, but they really didn't see much harm associated with it. I think only in one of the studies they mentioned somebody developing a slight rash, but otherwise they weren't seeing much harm, and it appeared to be improving the toxic shock, the patients who had toxic shock syndrome. Okay. Almost done. And then specifically with the streptococcal strep G patients. They had 7 out of the 15 got IVIG, and they had 4 of them survived after getting the IVIG out of the stomach. So it's debatable whether or not this helps or not, but I think seeing that the mortality is so high, I think it's probably worth it to treat them with this. But then there's some debate about expenses, there's a limited supply. So anyway, in summary, there are 2 kinds of toxic shock syndrome. There's staph and there's strep. They're rather different. There is some slight differences. Staph tends to be more localized, whereas strep is more invasive and tends to have tends to be a little bit more virulent. If you see sepsis plus a rash, hepatic dysfunction, thrombocytopenia, or early signs of DIC, you want to consider toxic shock. And there's some data out there that maybe IVIG could potentially help these cases. And I'll take questions. Yeah.
So I would use Banco until I knew for sure it was just strep. Do you think it could be staph? In this neighborhood and in a lot of other neighborhoods, you're going to have MRSA. And I don't think oxacillin is a good staph drug for non-MRSA, but it's not a good drug at all for MRSA. So I would use Banco. And if they're toxic, like you said, I would add Clinda, which is a very good strep drug. So is Banco. And then I think, if you're not sure yet if it's gram-negatives or anything, you could use either Zosyn, or if they have good renal function, then you can even use gentamicin, which is synergistic for certain types of strep and staph. When you use it, it's got to be worried because of the renal failure. But I definitely would include Banco around here until I knew for sure what organism it was.
Yeah, for sure. They did continue the Banco up until the blood cultures came back, positive for strep.
Good job.